Good morning. He probably doesn't need an introduction, but it gives me pleasure to introduce Professor Jason Grebely, who will be presenting on the effect of point-of-care RNA and dried blood spot testing on initiation of treatment among people with HCV attending Netherlands syringe programs.
Just one question to the AV. Could you make it full screen without the notes, please? If that's possible. Anyways, okay. Well, thank you so much. And just hello, everyone. Jason Grebely, and looking forward to the last day of the conference. Before I begin, I would just like to acknowledge the traditional custodians of the lands on which most of this work was done. I live on the lands of the Bidjigal people of the Eora Nation. And I'd also just like to acknowledge all the people with lived and living experiences that are here at the conference, and just acknowledge all the lives that have been lost to the war on drugs. It was interesting, when I was thinking about this presentation, I went back and we've been talking a little bit about how long research takes, and it's actually, this has been a 10-year journey. So it's my absolute privilege to present this work to you today on behalf of a wide range of individuals. Here's my disclosure. I also would like to just thank and acknowledge the generous support from the funders, in particular Cepheid and Gilead Sciences and Hologic, who provided the funding for the trial. Also, there is an absolute army of amazing nurses, research assistants, principal investigators that were contributing to the trial. Some of the people here in the room. Special shout out to one of my colleagues and mentors, Alex Wade, who I know is here. Amazing nurse. Without this work, those people, this work wouldn't get done. Oh, and also the two main study coordinators, Elise Tu and Jesse Payne, who are just absolute legends, and the team at Kirby. All right, so a major barrier to improving testing and treatment for hepatitis C is that we have this diagnostic testing pathway where you've got multiple visits and people get lost to follow up along the way. And we have these new simplified technologies, so dry blood spot testing and point of care, and they've been shown to improve initiation of testing, or testing and initiation of treatment. We did a pilot study looking at point of care RNA testing at a community-based needle syringe program in Sydney, and showed a treatment uptake of 81%. However, the majority of studies to date looking at both dry blood spot testing and point of care have lacked control arms often. They've been small sample sizes, and there's very, very few randomized studies that have been done to date. So with that in mind, we wanted to compare the initiation of treatment within 12 weeks of enrollment following point of care RNA testing, dry blood spot testing, or standard of care testing among people with recent injecting drug use with current Hep C attending needle syringe program services. This study was an investigator-initiated, Kirby UNSW-sponsored, practice-level cluster randomized trial. Participants were recruited from 16 primary needle syringe program services across Australia, and people were recruited as they were accessing needle syringe program services. Participants were enrolled and followed between August 2022 and July 2025. The delay of the study was held up by our friend COVID. The identification and inclusion criteria for the clusters was that you had to be a primary needle syringe program site defined as providing services to people who inject drugs by staffed specialist workers. They had to have capacity for on-site nursing support, either there or externally, and also to be able to provide treatment. And they had to provide services to at least 60 people per week. The inclusion criteria for the participants is that they had to be greater than 18 years of age or have had recent injecting drug use defined by use in the previous 6 months. The eligibility criteria for treatment was that they had to have current infection, so this was detectable and quantifiable RNA. And they needed to be eligible as per government guidelines to initiate treatment with either sofosbuvir valpattosvir or glucapavir pibrentasvir. Here's the study design. The study was meant to enroll 18 sites. 6 sites were randomized to dry blood spot testing, with then the sample being sent to a centralized lab. Participants were then text messaged the results and noted to come back to receive treatment. Individuals in the point-of-care arm were intended to have same-day test and treat. You'll see that this didn't happen in the majority of cases. And the individuals with standard of care were referred for nursing assessment and then had standard lab-based assessments. This is the study procedures. So essentially at testing in all three arms, there was a screening visit. I want to note an important component to the study design in that everybody in the standard of care arm also received dry blood spot testing so that we could test the individuals that were lost to follow-up, so we would know who the eligible population was in terms of those with current infection. So the control arm then had a series, everybody went on to standard of care visits. I just want to note that the one difference between the arm is that between the intervention and control arms is that those in the intervention arms had standardized 12-week and 24 and 1-year follow-up visits. We didn't want to bias the trial to intentionally bring people back in the standard of care arm so as not to increase treatment uptake in that population just by the engagement with the healthcare providers. The outcomes, so the primary objective, we wanted to compare the proportion of HCV RNA positive people who initiated treatment at 12 weeks between those who received point-of-care RNA testing, dry blood spot testing, or standard of care. There were a range of secondary objectives. I'm not going to go through those today. I will just be speaking about the primary endpoint and a couple secondary endpoints. I also need to clarify that the primary hypothesis was that compared to standard of care, that an intervention of either dry blood spot testing or point-of-care testing would lead to an increased proportion of people who initiated treatment within 12 weeks. We also had a secondary hypothesis, which was comparing standard of care to point-of-care testing, okay? And this is important because in the sample size calculations, we estimated an RNA prevalence of about 15 to 20%, and we estimated that 150 people would need to be screened to get a cluster size of 25 people with current infection. We had an intercluster correlation coefficient of 0.05, 90% power, and an alpha of 0.05. So for the control versus combined intervention arm, we had a comparison of 6 sites versus 12 sites. We assumed this number of individuals, and under these assumptions, we were powered to detect a difference of treatment uptake of 17% between the control and intervention arms. For the control versus the point of care or the dry blood spot, we had a power to detect a 25% difference between the control and intervention and the point of care testing arm. All right, so here's the characteristics. Overall, 19 clusters were actually randomized, but only 16. I'll just draw you to the overall. You can look at the other arms. Only 16 sites ended up being enrolled. You can see the numbers there, 5 in the standard of care, 5 in the dry blood spot, and 6 in the point of care arm. You see that we did not hit the 150 estimated, and also, so 113 mean individuals enrolled per cluster. The number of people with current HCV was 14, so smaller than the 25 that I noted. And the proportion of people with current infection was 11%. So I mentioned this was a 10-year journey. We estimated that the prevalence would be between 15 to 20% per site, and it ended up being 11% as Australia has been successfully eliminating hepatitis C. So it made it a big challenge. We recruited less people than we thought, but this is the case. We had to stop the study early. Overall, there were 1,801 individuals enrolled. In those, there was 182 people that were not tested as per their allocated arm. So what this means is, for example, in the standard of care arm, they didn't come back for their venipuncture result, so they had a dry blood spot test. And so we know their current infection status because of the dry blood spot testing that was done on that day. So a really important thing when you're thinking about trial design when you're having a control arm like this. So overall, there were 209 participants with current HCV, and you can see the distributions across the arms. The participant characteristics overall, so median age of 44, 37% female, 37% First Nations identity, about a quarter were currently homeless, about a third were currently receiving opioid agonist treatment, and you can see that 80% had injected in the last month, and 38% had injected greater than daily. You see a couple of people who obviously said yes, they wanted to be enrolled in the study and had recent injecting, and then reported no on the survey, hence the discrepancy there. This is the characteristics in those with current HCV, so median age 48, 31% female. I won't go through them all, I guess, to say that they're reasonably similar to the characteristics in the overall population, and you can see that the characteristics across the groups were reasonably well balanced. All right, so the final analysis. This is looking at the treatment initiation within 12 weeks of enrollment. So the overall proportion that initiated treatment within 12 weeks was 24%. It was 14% in the standard of care arm, 14% in the dry blood spot testing arm, and 38% in the point of care testing arm. This is the individual treatment uptakes by site. Really interesting. You can see that there's actually quite a bit of heterogeneity across the sites, ranging from 5% to 100% in the standard of care arm. You can see ranging from 0 to 33% in the dry blood spot testing arm. Perhaps that site with a 0% dropped the treatment initiation a little bit. And you can see that the point of care testing arm, there was one site that did not enroll any positive individuals or people with current infection. And this treatment uptake ranging from 27% to 67% in that arm. This is the treatment initiation within 12 weeks, and I've shown you this this is looking at using regression analyses, and you can see that the control versus the intervention combined arms with an unadjusted odds ratio of 2.10, so they had a 2.1 greater odds, although this was not significant, but you can see that the control standard of care versus point of care arm, there's a 3.96-fold greater odds of initiating treatment in the point of care arm compared to control, and this was significant, and there was no difference between the control and DBS arm. This is just looking at time to treatment, so you can see a much more rapid time to treatment in the point of care testing arm compared to both of the other arms. So in conclusion, compared to standard of care among people with HCV among recent injecting drug use attending NSP services, the combined intervention of dry blood spot testing or point of care testing were not associated with an increased proportion who initiated treatment within 12 weeks following enrollment, but point of care RNA testing was associated with an increased proportion who initiated treatment at 12 weeks following enrollment compared to standard of care. You can see that there is considerable heterogeneity across the sites, particularly with the standard of care group, and further work is really needed to understand the long-term impact of these interventions on initiation of treatment. So I think one of the key questions is does point-of-care testing increase treatment uptake over the long term, or does it just make it faster for you to get onto treatment? I will say that we have looked at the data out a little bit longer. We're just waiting to censor it, but obviously these treatment uptake proportions do come up over time as you go on further. You probably get about a 15 to 20% increase in treatment, say up to 1 year. And further research is really needed to understand the barriers and enablers for implementation of point-of-care testing so that we can develop strategies to improve treatment initiation in this population. And this is where some of the implementation science methodologies that we've been talking about might be useful. That is it. I'm bang on time. Massive thanks to everyone for all of their acknowledgement. Appreciate it.
Thank you so much for that great presentation, Prof. Jason. We've got about 3 minutes for any agent questions.
Hi, thank you, Jason, for that great presentation. I'm Eugenia Socias from University of British Columbia in Canada. I have 2 questions. The first one, as you noted, there were a lot of heterogeneity between the sites. Have you collected data on the characteristics of the sites, if there were other supports that could have improved the outcomes? And are you planning on looking into that?
Yeah.
Sorry.
Go ahead.
Yeah, my second question, you presented time to treatment initiation, but you were also had the endpoints of SVR12 and I guess the longer term outcomes. Are you gonna be looking at those, not just as you're saying, where this improved treatment initiation, but actually improve treatment completion and SVR?
Sure. So to answer your first question, we did collect information on the differences between the sites. I think it'll be very difficult with the small number of clusters to make much sense of that information. But what we are doing is we're in collaboration with Natalie Taylor and Guillaume Fontaine, who are here at the meeting. We're doing very detailed process mapping and implementation science work to characterize the barriers and enablers of the testing and treatment pathway. And then we're designing interventions to address barriers and amplify the enablers using implementation science methodologies so that we can enhance point-of-care testing in these services. To answer your second question, absolutely. Treatment completion, cure, and all those other important treatment-related endpoints we'll also be evaluating as part of the study, including the proportion of people receiving sofosbuvir valproatovir and glecaprevir preventsphere and so forth. So yeah, thank you.
Hi, Jason. My name
About
is... Sorry.
less than a minute for your question. Thanks.
It's a quick one. Thank you so much for your talk. My question is, did you look to see how quickly it took to process the dried blood spot testing and whether that had an impact on all of your findings?
Yeah, we did. I don't have the exact, usually on average it was about a week for processing of the DBS sample. They do them in batch testing through a state-led state-led dry blood spot testing program that's run by the Ministry of Health. So those were just added to those batches and done at a regular basis. So the time to result was reasonably quick. Great. Thank you so much. Really appreciate it.
Thanks, Jason. And thank you for the questions.